In this session, we'll be dealing with the gross anatomy of stomach. So, stomach is the most dilated part of the gastrointestinal tract. Location is in epigastrium, left hypochondrium, and umbilical regions when the stomach is moderately distended. Capacity in newborn it is 50 to 100 ml. In adults it is 1000 to 1500 ml. Fundus is filled with air, approximately around 50 ml, even when the stomach is empty. Shape is J-shaped. The normal shape is sthenic. So long limb of J is slightly oblique. So hypersthenic. Long limb of J is more oblique. It is looking like steer horn. So that's why this kind of hypersthenic stomach or steer horn stomach is more prone for duodenal ulcer. Then hyposthenic, the long limb of J is vertical, and this kind of or this shape of stomach is more prone for gastric ulcer. You can see here, this is a hypersthenic, this is a sthenic, this is hyposthenic, and this is asthenic. So in this, you can observe this kind of shape is more prone for duodenal ulceration. This kind of shape is more prone for gastric ulceration, and this is the normal shape. So this is the axis of stomach when the stomach is empty, and here this is the axis when the stomach is full. You can see here almost the axis is going from the summit of the fundus to the pyloric antrum. So here the axis is going to the from the left of the fundus to the right of the pyloric antrum. So features: two orifices. There will be cardiac orifice and a pyloric orifice, two curvatures, lesser curvature and greater curvature, two surfaces, anterior superior surface and posterior inferior surface, two notches, cardiac notch and angular notch. Parts will be fundus. So this is above the horizontal plane passing through the cardiac notch. So it extends up to left fifth intercostal space. So when this fundus is distended, so it will cause cardiac distress. So body extends between fundus and pylorus. The pylorus is actually we can identify the pylorus by an imaginary plane from angular notch to the notch on the left of the pyloric antrum. So pyloric antrum is around 7.5 centimeters and pyloric canal is around 2.5 centimeters. So both are separated by sulcus intermedius. So fundus is separated from body by this horizontal plane which passes through cardiac notch, and body is separated from pylorus by an imaginary plane which passes from angular notch to the notch on the left of the pyloric antrum. I'll show you in the next diagram. You can see here, this is the fundus, so which is the part of the stomach above the horizontal plane which is passing through cardiac notch, and this is the pylorus. So you can see this is the imaginary plane passing from angular notch to the notch on the left of the pyloric antrum. So this is the pyloric antrum. So now if you see, there will be two orifices. This will be the cardiac orifice and this will be the pylorus, and there will be two curvatures. This will be the lesser curvature and this will be the greater curvature, and there will be two surfaces. What we are seeing is the anterior superior surface and behind will be the posterior inferior surface, and you can see two notches. This is the cardiac notch and this will be the angular notch. And if you observe, this is the entire pylorus. So you can see here, this is the pyloric antrum and this is the pyloric canal. Both are separated by sulcus intermedius. And if you see this pyloric antrum, the pyloric antrum is nothing but the dilated greater curvature opposite the angular notch. So fundus, body, pyloric antrum, pyloric canal, sulcus intermedius, and this will be the pyloric orifice. This will be the cardiac orifice. Lesser curvature and greater curvature. Cardiac orifice, 2.5 centimeters to the left of midline. So this lies 2.5 centimeters to the left of midline, and it is behind the left 7th costal cartilage opposite T11 vertebrae. So in front, cardiac orifice is covered with peritoneum and related to left lobe of liver. Behind, it is related to triangular bare area of stomach and connected to left cross of diaphragm by gastrophrenic ligament. So you can see here, this is the cardiac orifice. You can see the circular muscle of the stomach is continuous with the esophagus. And pyloric orifice, you can see in living, this will be identified by pre-pyloric vein of Mayo, and it remains open in empty stomach. So that means when stomach is empty, pyloric orifice is open, and it is situated 1.5 centimeters to the right of midline, and the vertebral level is lower border of L1. So in front, it is covered with peritoneum and related to quadrate lobe of liver and the falciform ligament. Behind, it is related to neck of pancreas separated by lesser sac. You can see here, this is a pyloric sphincter, this is a cardiac sphincter. The cardiac sphincter is more physiological, pyloric is both anatomical and physiological. Lesser curvature, it forms right border of stomach, presents angular notch, lesser momentum is attached to it. Anastomosis of right and left gastric arteries and gastric nerves lies along the lesser curvature. Greater curvature begins at cardiac notch, slightly to the left of the cardiac end. Then the following ligaments are attached to the greater curvature, namely the gastrophrenic ligament, gastrosplenic ligament, and anterior two layers of the greater momentum. Opposite angular notch, greater curvature bulges as pyloric antrum, limited by notches on either side, as I have shown in the earlier diagram. So now anterior superior surface, the gastric impression of the left lobe of liver and quadrate lobe of liver. So these are the most important relations. Then spleen, then diaphragm. So this diaphragm is related beneath the left costal margin. So then left pleura, left lung base, then pericardium, heart, and left 6th to 9th costal cartilages. Then spleen is separated from the anterior superior surface of the stomach by the recess of greater sac. Then gastric triangle. So it is the area of stomach in direct contact with anterior abdominal wall. So this is the site for gastrostomy operation in complete esophageal obstruction. So boundaries will be, on right side it is the lower border of liver, on the left side it is left costal margin, below it is transverse colon. I can show you here. So this is the gastric triangle which is in direct contact with the anterior abdominal wall. So during nasogastric intubation, to know the whether the nasogastric tube is in position or not, we can auscultate in this area by flushing air through the nasogastric tube. You can see this is the right side lower border of the liver. So this is the left side, left costal margin, and this is below the transverse colon. So all these three are the boundaries for the gastric triangle. So then you can see the trough space. So it overlies the fundus and it is tympanic on percussion. Boundaries above will be the lower border of the left lung, below will be the left costal margin. On right side it will be the lower border of left lobe of liver, left will be the lateral end of spleen. So it will be obliterated either by enlargement of the liver or by enlargement of the spleen or by the pleural effusion. You can see here. So this is the trough space, above bounded by the lower border of the left lung, below by the left costal margin, on the left side by the lateral end of spleen, and on the right side by the lower border of the left lobe of the liver. Posterior inferior surface rests on stomach bed structures. The following are the structures which form stomach bed: left crus of diaphragm, left suprarenal gland, left kidney, splenic artery, pancreas. So anterior surface of the left kidney and pancreas. Then anterior layer of transverse mesocolon, anterior layer of transverse mesocolon. Then sometimes left colic fracture. And if the stomach is distended, then only the gastric impression of spleen comes in contact with the posterior inferior surface. Otherwise, it will be related to the anterior superior surface separated by a recess of greater sac. You can see here, this is the diaphragm, this is the left suprarenal gland, this is the left kidney anterior surface, this is the anterior surface of the pancreas, this is the anterior layer of the transverse mesocolon. Same diagram here, left suprarenal gland, left kidney, splenic artery, pancreas, diaphragm, transverse colon and mesocolon are removed here. Now this is the interior of the stomach. See this rough impressions or folds. These are important for mixing the food contents. And if you observe from cardiac orifice to the pyloric canal along the lesser curvature is the gastric canal. So liquids tend to pass through the gastric canal. They will not be spreading more towards the greater curvature. Arteries. The following arteries supply the stomach. You can see here the left gastric artery which is a branch from celiac trunk, right gastric artery which is a branch from common hepatic artery, left gastroepiploic artery which is a branch from splenic artery, right gastroepiploic artery which is a branch from gastroduodenal artery, short gastric arteries 3 to 4 in number branches from splenic artery, and posterior gastric artery which is a branch from splenic artery. You can see here this is the left gastric artery which comes through the superior gastropancreatic fold. And you can see the right gastric artery. Left gastric artery is a direct branch from celiac trunk. Right gastric artery is a branch from common hepatic artery. You can see the right gastroepiploic artery is a branch from gastroduodenal artery, and you can see the left gastroepiploic artery is a branch from the splenic artery. And you can see these are the short gastric arteries which are coming from the splenic artery, and occasionally there will be posterior gastric artery. So venous drainage. The veins which drain into portal vein are the right and left gastric veins. The veins which drain into splenic vein are the short gastric veins and the left gastric pubic veins. The veins which drain into superior mesenteric vein are the right gastric pubic vein. You can see from this diagram, the left gastric vein and right gastric vein both are draining into the portal vein. You can see here at the lower end of esophagus, the tributaries of the left gastric vein and the tributaries of the inferior hemigastric vein are forming portocaval anastomosis. In portal hypertension, this is the area where esophageal varices will arise and leads to hematemesis. Here you can see the right gastric pubic vein draining into the superior mesenteric vein, the left gastric pubic vein draining into the splenic vein, and short gastric veins draining into the splenic vein. Lymphatic drainage. So for convenience, the stomach will be divided into left side and right side. Left side of the stomach, majority of the lymphatics drain into the pancreatico-splenic lymph nodes. Sometimes they also drain into the paracardiac nodes. Upper two-thirds of the right side of stomach, it drains into the left gastric nodes. Lower one-third of the right side of stomach drains into right gastric pubic nodes, which ultimately drain into pyloric nodes. From the pylorus, it will go in three directions, reaching the hepatic nodes, left gastric nodes, and pyloric nodes. You can see here. So if we draw an imaginary line like this, separating the stomach into right part and left part, from the left part, majority of the lymphatic goes to pancreatico-splenic nodes, and few are intervened by the paracardiac nodes. And if you see the right side, upper two-thirds drains into left gastric and lower one-third drains into right gastric pubic, which ultimately drain into pyloric. And the pyloric canal drains into three different nodes, namely the left gastric, hepatic, and pyloric. Ligaments of the stomach: lesser omentum, greater omentum, gastrosplenic ligament, gastrophrenic ligament, and left or superior gastropancreatic fold. This will be discussed in relation with the peritoneal folds. So time being, we can appreciate the gastrosplenic ligament, the greater omentum, and the lesser omentum having two parts. This will be the hepatogastric part and this will be the hepatoduodenal part extending between liver and duodenum. And this is hepatogastric part extending between liver and the stomach. So this is the sympathetic nerve supply. You can see here the preganglionic fibers arise from T6 and T9 and they pass through the greater splanchnic nerve and reach the stomach. So actually they reach the celiac plexus where they relay, and from celiac plexus postganglionic fibers will go around the around the blood vessels to reach the stomach. And you can see this green color structures. This green color structure are indicating the sensory fibers or sensory sympathetic fibers which carry pain sensation. Sympathetic is carrying pain sensation from the stomach. Please remember, sympathetic is carrying pain sensation from the stomach. So preganglionic fibers are from T6 to T9, reach celiac plexus by greater splanchnic nerves. Postganglionic fibers travel around arteries to reach stomach, primarily vasomotor, and sensory sympathetic fibers carry pain. So parasympathetic is mainly by the vagus. You can see here this is the anterior vagal trunk, which is divided into hepatic branches and gastric branches. The main gastric branches are the nerves of Latarjet. They are supplying the anterior superior surface. You can see this is the posterior vagal trunk having celiac branches and gastric branches. Main branches from the posterior vagal trunk are the nerves of Latarjet supplying the posterior inferior surface. Functional components, you can see here the sensory component going through the vagus nerve. The neurons are located in the nodus ganglion. They actually carry nausea and vomiting sensation. The pain is carried by the sympathetic, whereas nausea and vomiting is carried by the parasympathetic. And you can see this is the parasympathetic innervation. It is mainly secretomotor to glands. And you can see here secretomotor to the glands, motor to gastric musculature, and inhibitory to pyloric sphincter. Sensory fibers are concerned with hunger and nausea. So there will be hepatic branches and celiac branches which are secretomotor to glands and augment peristalsis. So this parasympathetic supply will go up to right two-third and left one-third of the transverse colon, kidney, gonads, and pancreas. This vagus is having parasympathetic innervation up to this point, that is right two-thirds and left one-third of the transverse colon. Applied aspects: hypertrophic pyloric stenosis. It's a congenital defect. So surgically the hypertrophied pyloric muscle has to be divided. So this procedure is called Ramstead operation. Then if you see the treatment for non-responsive gastritis to the medical line of treatment, you can go for surgical treatments like truncal vagotomy, selective vagotomy, and highly selective vagotomy. In truncal vagotomy, directly the trunks are cut. In selective vagotomy, nerves of Latarjet are cut. And in highly selective vagotomy, only the left branches of the nerves of Latarjet are cut. You can see here. So this is the pyloric stenosis. So you can see here, this is the truncal vagotomy. Anterior vagal trunk is cut. esophagus is mobilized, then the posterior vagal trunk is cut. And here you can see the highly selective vagotomy, where only the left branches of the nerves of lateral jet are cut. And here the pyloric part nerve supply is kept intact so that gastric motility is not disturbed. Thank you.